So
Good afternoon.
let's listen to
First of
her.
all, let me thank Dr.
Welcome.
Vaishali Deshmukh for inviting me to this Synapse conference. I'll be speaking on year in review, pharmacological treatment for diabetes and obesity. So what transpired in the last 1 year in the management of diabetes and obesity? This is the agenda of my talk. Therapeutic updates in diabetes, therapeutic updates in obesity. So F-peglanetide, this is a long-acting GLP-1 receptor agonist. It's a single amino acid modified exendin conjugated to a fragment crystallizable, that is the FC region of the human immunoglobulin 4 via a mini polyethylene glycol linker. This is the structure of F-peglanetide. Amino acid modification in the CA-exendin 4 reduces the extent of its degradation by DPP4. The large size of the overall molecule may reduce its rate of renal clearance. The PK/PD profile allows flexible dosing. Phase 2 study dosing range from once weekly to potentially once monthly has been tried. These are some of the studies which has been done. Exit 203 phase 2 study, type 2 diabetes, either drug naive or metformin monotherapy, where they found there is a superior HbA1c reduction and body weight versus placebo. And the exploratory data found that the HbA1c reduction with F-peglanetide 4 milligram were non-inferior to those with lidocaine full dose, that is a 1.8 milligram. And then there was a phase 2 study known as a Liberate 204, type 2 diabetes drug naive or maximum tolerated dose of metformin. And then you had a phase 3 study, that is an Amplitude O trial, where type 2 diabetes either ASCVD or CKD plus additional CV risk factors. They looked into the MACE events and composite renal outcome events were significantly lower versus placebo. There was significantly greater reduction in A1C versus placebo. The least squares mean difference was 1.2% during the follow-up period. And the Amplitude EM, which is a phase 3 study, efficacy and safety, patients with type 2 diabetes 1:1:1 randomized to 1 or 3 doses of F-peglanetide, which is 2 milligram, 4 milligram, 6 milligram, or placebo subcutaneously weekly. So what you can see here is there was a superiority of all doses of F-peglanetide over placebo and HbA1c reductions from baseline versus placebo till 56 weeks. And a maximum decrease happened with the 4 and the 6 milligrams versus placebo. If you see A1C less than 7%, it was achieved in around 73.8% the 6 milligram dose and 65 and 60 in 4 and 2 milligram dose respectively versus placebo, which is 25.5%. And A1C less than 6.5 was achieved with 58.3%, 48.5 and 44, 6, 4 and 2 milligram respectively. A1C less than 7 at the end of 56 weeks was seen in 57.4% with 6 and 4 milligram and 54 in the 2 milligram dose. And A1C less than 6.5 was seen, in fact, with the 4 milligram dose of around 46.5 and 6 milligram, it was 42.7 and 39% of the 2 milligram dose. So what I found here in this Amplitude M trial was as monotherapy in patients with type 2 diabetes, once weekly F-peglanetide significantly improved glycemic control and body weight with a safety and tolerability profile similar to that of other GLP-1 receptor agonists. Then coming to the next newer molecule, that is dorzagliatin. This is a novel first-in-class dual-acting allosteric glucokinase activator. This directly binds to a pocket distal to the active site of glucokinase, increases its affinity for glucose, and lowers the set point for glucose-stimulated insulin secretion. So GCK-MODI, that is the common garden type 2 or MODI2, have a marked reduction in beta cell glucose sensitivity and impaired alpha cell glucose sensing. So a phase 3 double-blind randomized crossover study was done, 8 participants with GCK-MODI and 10 participants with type 2 diabetes. They underwent 2-hour hyperglycemic clamps following a single oral dose of dorzagliatin, 75 milligram, or matched placebo. In GCK-MODI, dorzagliatin significantly increased absolute and incremental second phase insulin secretion rates versus placebo, but not the acute insulin response. So you can see here, the plasma insulin levels in patients with GCK MODY was more when the dorzagliatin group, the second phase insulin response. And in patients with type, this is during the hyperglycemic clamp. And dorzagliatin increased the basal insulin secretion rate in type 2 diabetes with smaller changes in second phase. And they looked into different GCK mutations and looked at the insulin secretion rate in these patients. In the serine 340 arginine, it rescued the enzyme activity comparable to that of the wild type GCK MODY. It restored enzyme activity, remained lower when you had the cysteine 220 tyrosine, and no action was detected with or without dorzagliatin in the alanine 378 cysteine FSTR81. So what did they conclude? They concluded that dorzagliatin directly increased enzyme activity of selected mutant glucokinase and enhanced wild type GK activity, thereby correcting the primary defect of glucose sensing in GCK MODY. Coming to exenatide in youth with type 2 diabetes. So until recently, the only approved treatment for type 2 diabetes in pediatric patients were metformin and insulin. The results of the today, that is the treatment options for type 2 diabetes in adolescents and youth, found that 50% of the youth with type 2 diabetes fail metformin monotherapy within 12 months of treatment initiation. Rescue therapy with exogenous insulin in these age groups is associated with numerous challenges. Liraglutide has been FDA and the EMA approved as an add-on therapy for pediatric patients with type 2 diabetes aged more than 10 years who have been receiving metformin with or without basal insulin. So ELLIPSE trial, this is liraglutide when added to metformin with or without basal insulin, was superior to placebo in children and adolescents with type 2 diabetes in reducing glycated hemoglobin levels at 26 weeks. Here they wanted to look into exenatide in youth with type 2 diabetes. So once weekly exenatide in youth with type 2 diabetes. Participants were aged between 10 and less than 18 years. They were randomized 5:2 to once weekly exenatide 2 mg or placebo. The primary efficacy endpoint was a change in glycated hemoglobin from baseline to week 24. 89 participants were randomized, 59 to the exenatide group, 24 to the placebo group. 72 completed 24 weeks treatment, exenatide 49 and placebo 23. So you can see at week 12 as well as week 24, the exenatide group did better. And if you see the between group least square mean difference at week 24, once again, it was better with the exenatide group. So what they concluded, in youth with type 2 diabetes, suboptimally controlled with current treatments, once weekly exenatide reduced glycated hemoglobin at week 24 weeks and was well tolerated. What about once weekly dulaglutide for the treatment of youths with type 2 diabetes? So this came in the New England Journal, the Awards Pets Investigators. This trial compared once weekly dulaglutide with placebo for glycemic control in youth with type 2 diabetes who may have been receiving metformin or basal insulin, and they found that dulaglutide was superior at 26 weeks. This was a double-blind, placebo-controlled 26-week trial. Age group 10 to less than 18 years of age, BMI more than 85th centile, being treated with lifestyle modification alone or with metformin with or without basal insulin, randomized 1:1:1 ratio to receive once weekly dulaglutide injections of 0.75 milligram or 1.5 milligram or placebo injections. Participants were then included in a 26-week open label extension study in which those who had received placebo began receiving dulaglutide at a weekly dose of 0.75 milligrams in the extension. So overall, what they found was, if you see the change in baseline and glycated hemoglobin, the 1.5 milligram group did better than the 0.75, and overall there was a decrease by around 0.9. And if you take the pooled one, 0.8% decrease. Glycated hemoglobin of less than 7% percentage of participants overall Pooled one, 51% achieved an A1C less than 7%. If you see the change in fasting plasma glucose, pooled value around 19 milligrams decrease. With the 1.5, it was 24.9 milligrams lesser versus placebo, where it was around 17.1 milligram increase. And the change in baseline in BMI was pooled ratio was around 0.1 decrease the BMI, the least square mean change. So treatment with dulaglutide at once weekly dose of 0.75 or 1.5 milligram was superior to placebo in improving glycemic control through 26 weeks among youths with type 2 diabetes who were being treated with or without metformin or basal insulin without much effect on BMI. R form of verapamil in type 2 diabetes. Incretin hormone mimetics have been shown to ameliorate beta cell apoptosis and increase beta cell mass in rodent models. But these effects have not been replicated in human clinical trials, possibly due to intrinsic differences between species, beta cell physiology, and the use of different treatment protocol. This R form, the racemic form, is verapamil is a phenyl alkylamine calcium channel antagonist used in the management of hypertension, arrhythmia, and angina. It's been shown to play a role in preventing insulin-producing beta cell death in vivo and in vitro studies. The mechanism of action being inhibition of extracellular calcium penetration through cell membrane, reduction of intracellular calcium levels, and inhibiting the expression of pro-apoptotic thioredoxin interacting protein, which would otherwise accumulate in the pancreatic beta cells and increase oxidative toxicity. This R form is being tested as an investigational protocol for the treatment of type 1 diabetes. Verapamil at high doses has been used in heart failure, AV block, hypertension, and rapid ventricular response. And the R and S enantiomers have differing levels of pharmacological activity. The S form of verapamil demonstrated 8 to 20-fold higher potency to slow AV conduction and 15 to 50-fold higher potency to reduce myocardial contractility in animals and humans. So the R form verapamil is likely to reverse beta cell apoptosis and type 2 diabetes progression with higher cardiovascular safety margin. So an RCT of this R form verapamil added to ongoing metformin therapy in type 2 diabetes was done from Taiwan. So the group included patients with type 2 diabetes aged between 18 to 75, diagnosed with diabetes at least for 12 weeks, A1C more than 10, less than 10 and more than 7. Fasting should have been less than 260, BMI 20 to 45, and they should have adequate liver function. GFR should be more than 45 ml per minute, and they should be on a stable dose of monotherapy of metformin, 1500 milligram or greater for at least 3 months. Total randomized 184, 46 placebo, 150 milligram R verapamil in 46 patients, 300 milligram in 47 patients, and 450, 45 patients. So overall, you can see when they used the change in A1C was highest with the 450 milligram, 0.81 decrease versus 0.67 versus 0.39 with 300 and 150 milligram respectively versus placebo, and they were all statistically significant. If you see the change in A1C, it was actually greatest, you can say, with the 300 milligram compared to that of the 450 or the 150 milligram. And subgroup analysis with the baseline more than 130 milligrams. So you can see patients with 300 and the 450 had a significant decrease of A1C. Change in A1C was significant in the 300 and the 450 milligram versus that of 150, which was also significant compared to that of placebo. If you see the adverse events, they were almost similar between the placebo and the various groups of R verapamil. Hardly any changes except, in fact, in one group in the placebo arm had an upper abdominal pain. And overall, if you see, nothing much. Urinary tract infection were actually greater in the placebo compared to that in the verapamil group. So what they concluded here was addition of R verapamil twice daily to ongoing metformin therapy significantly improved glycemic control in type 2 diabetic patients. The favorable efficacy and safety profile of R-verapamil 300 milligram per day can be considered as the appropriate dose for clinical practice. Now, coming to the second part, therapeutic updates in obesity. So once weekly semaglutide in adolescents with obesity. So came in the New England Journal, the STEP Teens investigators. In this trial, adolescents with obesity assigned to weekly subcutaneous semaglutide plus lifestyle intervention had a greater reduction in BMI than those who received lifestyle intervention alone. So this was a phase 3A multinational double-blind parallel group randomized placebo-controlled trial assess the efficacy and safety of semaglutide plus lifestyle intervention as compared with lifestyle intervention alone in adolescents with obesity. 201 adolescents aged between 12 to 18 years of age with a BMI more than the 95th centile or in the 85th centile with at least one weight-related coexisting conditions were assigned in a 2:1 ratio to receive subcutaneous semaglutide 2.4 milligram once weekly or placebo for 68 weeks. All participants and the parents received counseling about nutrition and physical activity for weight loss throughout the trial. The primary endpoint was the percentage change in BMI from baseline to week 68. So this was a study group. 134 received semaglutide and 67 received placebo. If you see the percentage change in BMI, 16% points decreased in semaglutide, whereas 0.6 increase in the placebo arm, and reduction of body weight of more than 5%, 73% in the semaglutide versus 18% in the placebo, both statistically significant. What about side effects? GI side effects was more in the semaglutide arm. Any disorder, nausea, or vomiting was more in the semaglutide. So they concluded among adolescents with obesity, once weekly treatment with a 2.4 milligram dose of semaglutide plus lifestyle intervention resulted in a greater reduction in BMI than lifestyle intervention alone. Tirzepatide once weekly for the treatment of obesity. So tirzepatide, this is a dual GIP GLP-1 receptor agonist, has been shown to reduce weight in type 2 diabetes. Whether it can reduce weight among non-diabetic patients with obesity has not been assessed. So this study was done tirzepatide once weekly for the treatment of obesity, the SURMOUNT-1 study. It's an international phase 3 double-blind randomized involved 2,539 adults, obese or overweight, plus weight-related complication without diabetes. They received once weekly injections of tirzepatide for 72 weeks. One group received tirzepatide 5 milligram or 10 milligram or 15 milligram versus placebo. So you can see the weight change. The weight change from baseline percentage, 15% with the 5 milligram group and 19.5% with the 10 milligram group and up to 20.9% in the 15 milligram group versus 3.1% with the placebo arm. More than 5% weight reduction at 72 weeks. Almost all of them, 5, 10, 15, more than 85%, reaching up to 91% in the 15 milligram group. And events occurring in more than 5% of participants. Yes, we can see compared with placebo, nausea was more, diarrhea was more, and constipation was more with the tirzepatide group. So in this 72-week trial in participants with obesity, 5, 10, and 15 milligram of tirzepatide once weekly provided substantial and sustained reduction in body weight. Coming to FGF21 analog for hypertriglyceridemia. FGF21 was first identified as a potential metabolic factor in a screen for proteins that induce glucose uptake in adipocytes independent of the glucose 4 transporter. This is one of a broad family of FGF proteins with diverse action. FGF 19, 23, and 21 are considered endocrine FGFs as they are secreted directly into the circulation. All the FGFs signal through 4 FGF receptors. The endocrine FGFs 19 and 21 distinctly require beta-klotho as a co-receptor for signal transduction. These are broadly expressed in various tissues and organs. Secretion by the liver accounts for most of the FGF21 in the circulation. Expression of beta-klotho is more limited with substantial expression in the liver, white adipose tissue, brown adipose tissue, pancreas, and discrete areas of the brain, contributing to metabolic specificity. FGF1 is increased in mice by starvation or consumption of a ketogenic diet. It increases with protein restriction, ingestion of fructose or alcohol, or rise with obesity. Preclinical studies, FGF21 treatment leads to both weight loss and reduced liver fat, attributed to increased fatty acid oxidation. It decreases triglycerides and LDL cholesterol, increases HDL, and improves insulin sensitivity. So LLF580 and FGF21 analog reduces triglycerides and hepatic fat in obese adults with modest hypertriglyceridemia. So done in US. So inclusion criteria, adults with a BMI of 30 to 45 kgs per meter square, inclusive with ethnic adjustment, more than 27.5 kg per meter square for Asian. Fasting triglycerides should be between 150 to 500. Exclusion criteria, known hepatobiliary disease, LFT is above upper limit of normal. Chronic infection with HIV, hepatitis B, or hepatitis C. Fasting TG more than 500 were excluded, or concomitant use of a drug treatment for hypertriglyceridemia. History of bone disorders or low vitamin D, contraindications to MRI, change in body weight, use of weight loss drugs, or enrollment in a diet or weight loss or exercise programs. Assessed eligibility for 472, randomized 64 patients. Allocation with intervals, allocated to intervention, 31 were for placebo, and allocated to intervention active, 30. So if you see the FGF1 analog for hypertriglyceridemia, baseline demographics, they were almost same. The weight was around 102 kgs in the whole cohort and 105 in the placebo arm. They also subdivided them into baseline hepatic fat fraction more than 8% and less than 8%. They were almost matched, you can say. Around 90% had diabetes. So what they found here was the LLF580 lowered serum triglycerides by 54%, total cholesterol by 7%, LDL cholesterol by 12%, and increased HDL 36% compared to placebo. There were substantial reductions of liver fat of 52% over placebo in the setting of improved liver function test, the composite enhanced liver fibrosis score, and the N-terminal type 3 collagen propeptide, all were significantly reduced. Insulin and C-peptide levels and insulin resistance by HOMA-IR were all lower. Adiponectin, which was higher with the FGF21 analog treatment compared with placebo. Fasting glucose and glycated hemoglobins were unchanged. Reduction in biomarkers of bone formation without differences in the marker of bone resorption were observed. So LLF580 was generally considered safe, well tolerated, except for higher incidences of generally mild to moderate GI adverse effects. So the conclusion is, in obese, mildly hypertriglyceridemic agents, LLF580 was generally safe and demonstrated beneficial effects on serum lipids, liver fat, and biomarkers of liver injury, suggesting it may be effective for treatment of select metabolic disorders, including hypertriglyceridemia and non-alcoholic fatty liver disease. Coming to the last one, liraglutide for weight management in children and adolescents with Prader-Willi syndrome and obesity. So once again, study done from France. As you know, liraglutide is a GLP-1 receptor agonist that alters the activity of hypothalamic neurons in the arcuate nucleus, directly associated with eating behavior, thereby increasing satiety and reducing energy intake, leading to weight loss. It's been approved for weight management at once daily doses of 3 milligrams in adults with obesity with a BMI of more than 30 or overweight, BMI more than 27 with at least one weight-related comorbidities. In adolescents with obesity, liraglutide 3 milligram as an adjunct to lifestyle intervention is effective for weight loss and is approved for weight management in patients aged 12 to 17 years. So what about its usage in Prader-Willi? Given its benefits on appetite regulation and weight loss in adults and adolescents, this study aimed to investigate the efficacy and safety of liraglutide in children and adolescents with Prader-Willi syndrome and obesity versus placebo at 16 weeks, and versus no treatment at 52 weeks as an adjunct to structured diet and exercise program. So this is a 52 weeks randomized placebo-controlled parallel group trial, included a 16-week double-blind period and a 36-week open-label period with a 2-week off-drug follow-up period. So male or female adolescents more than 12 and less than 18 with a pubertal development TANS stage 2 to 5, and children aged more than 6 to less than 12 with a TANS less than 2 with genetically confirmed Prader-Willi syndrome were eligible for inclusion if they had obesity defined as a BMI corresponding to more than 30 kg per meter square for adults, more than the 95th percentile for age and sex, and stable body weight. So in the adolescent group, the randomized 32, 20 received liraglutide, 12 received placebo, and in the children, 17 received liraglutide and placebo received in 7. Totally, you can see 17 completed the trial, and in the exposed group, and placebo group 9 completed, around 15 completed in the liraglutide group and the placebo group 7. The BMI was around 36.3 in the liraglutide and 40 in the placebo group, and 37.8, 32.5 totally if you take in this. So total was around 37.8. This is, if you take the average, it was 37.8. If you take the children group, totally it was 24, 17 in the liraglutide had a BMI of 32.4, and the placebo had a BMI of 30.3. Change in the mean BMI SDS, week 16, p-value not significant. This is the estimated treated difference, though it was there, did not reach statistical significance. Week 52, once again, did not reach statistical significance. Estimated proportion of patients with more than 5% BMI reduction, not much difference, whether at week 16 or week 52. If you see the change in the BMI SDS, liraglutide versus placebo, you can say, though there was a decrease in both, not much significant. So the total score, if you see, the change in the mean hyperphagia questionnaire, total score, at week 16, not significant, but at week 52, it was significant. Hyperphagia behavior score, not significant. Hyperphagia drive score at week 52 was significant, and the severity score, not significant. So although the primary although the co-primary endpoints were not met, changes in the hyperphagia, total, and drive scores in adolescents warrant further studies on liraglutide in this population. So we'll have to see whether longer duration or a higher dose will probably help in this group with Prader-Willi syndrome. Thank you for patient hearing.
Thank you, sir. That was a very wonderful and elaborate identification. You really covered the grounds very well, and it was explored very beautifully, and you presented it in a very simple and a very lucid manner. Many thanks for the wonderful dissertation. Next, we have another stalwart with us.
Dr. Ganpathy is there for discussion. If Dr. Ganpathy is around.
I'm there.
Yeah, so we can have any questions. Dr. Anish is here, Dr. Harish is here. Do you all have any views, comments, or any points to be discussed by Dr. Ganpathy here? Any questions? I had one query about the verapamil study. So, what was the magnitude of hypotension in these patients and bradycardia?
Actually, if you see the adverse events, there's nothing. It was almost matched with the placebo. So even I am surprised. If you see the adverse, the chart, no?
Yeah, I saw that adverse event. That's why I was wondering. Yeah.
Yeah, it's all 0, 0, 0, 0. Everything is almost.
How would that be explained? That's what I was wondering.
No, even I don't know. But then that is how it is.
So we always thought that it is a bradycardia inducing drug. So a bit of skepticism to use it as.
The only thing is this is an R form, no? So that's the difference. The L form.
The racemeric form. Yeah,
probably. Yeah, that's why. Probably that.
Okay. may I say something? So far, we have been taking the diabetic drugs for giving CVOT benefits of giving cardiac benefits because of diabetic. This is the first time I'm seeing a cardiac or a hypertensive drug being pushed into the diabetic segment. I mean, the marriage is going the other way around.
The hope had shown for Ramipril actually. The Ramipril was known to be having benefit in diabetic population. But yes, right, what you're
Yeah.
saying.
That's right. Hope and also dream trial also reversal to from pre-diabetes to normal glycemia. You know, those things were there. But here we are using exclusively for its glucose lowering effect. That's really strange.
So it just explains probably that hypertension and diabetes are the spectrum of disorders that we are seeing with the same common background or pathophysiology. Probably, we don't know.
No, and no. The other thing is, one they told about the mechanism is via that what is the thioredoxin thing, because that will increase the. Normally, what happens is that will increase the apoptosis and all. It reduces that. The other mechanism is also is because calcium is required for insulin. What do you call stimulation? All these things. So via that also probably some action. So both of them theoretically, like for example, we used to use a calcium channel blocker types in patients with hyperpara, not hyperpara, parathyroid carcinoma. We tried all the things. Well, any theory thing is there, just give that medication, see whether it works. So it's all similar types. But
Yes.
only thing is this is an RCT and done properly.
I would congratulate you on an extensive study. I think you've covered nearly all the latest reviews for the latest molecule.
So I took in New England Journal of Medicine, the JCEM, diabetes care. So, and also a few things about JAMA also. So I thought I'll cover all of them. I wanted to see, I mean, you gave good time. That's more important. 30 minutes is a good time.
And we have a lot
Otherwise,
of
it'll all come
students. We have nearly about 70 delegates who have joined in this Saturday, Sunday afternoon. Lot of students. So, would you give some tips on reviewing studies? How did you do the review to begin with?
No, see, one thing is New England Journal, highest impact ones. So first choice is that. And the second, I chose ones, I mean, I would say by experience, of course, also. The newer things which have an impact for our future. So that's what we have to see. Now, for example, dorzagliatin, not so good study in the sense, hardly we see many patients of Modi. But then the semaglutide, the dulaglutide, the tirzepatide, that will be the molecule of the future because it's said that at least more than 10% or even more than that had a weight loss of 20%. That's a phenomenal decrease. So I think the one which has an impact factor should be taken into consideration. That's another way I looked into. And of course, some theory is required, like this, the R-verapamil form, those things, and the dorzagliatin.
Thank you so much for being here and giving your valuable comments. So over to you, Dr. Alok.
Just one question there. Semaglutide is coming up in a big way, both the oral as well as the subcutaneous form. And we are seeing in our own practice, Sema is giving very good results and it's getting accepted by patients, probably because
Correct.
it's not in an injectable form. What I don't understand is it's giving good results in obesity. And why the subcutaneous form has not yet been approved by the Indian authorities? I mean, why are
I think next year it should be available. And not only that, see, for step studies, they have used 2.4 milligrams. That's a still higher dose. What we use for diabetes is the 1 milligram ones, Ozempic. So the one which is being used for obesity is 2.4. That's a huge, 2.5 times more. And they have, once again, similar to tirzepatide, a good 20% reduction is happening. I think it should be coming.
So, sir, thank you very much for one.
Yeah, just one. Similarly, the oral semaglutide also, what we are using is 714. They are doing trials with 25 and 50 milligram for obesity now. Furthermore, the higher doses one. Yeah, thanks.
So, thank you once again, sir. That was a very lucid presentation, and it was an honor to listen to you.